it's my privilege to introduce Beatriz Fernandez Fernandez from Madrid, here to talk about expanding the range of kidney protection by SGLT2. Please.
Hello, everyone, and thanks for inviting me here to talk about expanding the range of kidney protection by SGLT2 inhibitors. I must confess some disclosures, and this is me. This is me doing my PhD in 2012. And whereas I was doing this PhD, this girl is now 15 years old, so long time ago, there was just this one, KDIGO guidelines 2012. And there was almost nothing in the horizon. That was what I was working with. I was working with RAS inhibitors. We started working with paricalcital, but that was a mess. We started working with bardoxolone, and it didn't work. So there was a lot of things not working in chronic kidney disease and not working in diabetic kidney disease. And my PhD was in diabetic kidney disease, so I had nothing to offer to my patients but a couple of pills that did something, but not everything. But everything changed for a while. And in March 2024, we found the World Kidney Day, and it said, Kidney Health for All. And what was Kidney Health for All? Well, I thought about that and said, March, it's the Ides of March. Do you know what are the Ides of March? The Ides of March has taken like some sort of symbolic overtones of preventing the tragedy. And we could prevent the tragedy. And then actually, KDIGO 2024 appeared one day before the World Kidney Day. This is the tragedy. CKD is a tragedy. It's a global healthcare problem. And it's a global healthcare problem that is increasing. It's going to be the second problem after Alzheimer's disease if we don't do anything about that. And it's more, in Spain, where I live, there's a lot of people with chronic kidney disease underdiagnosed. We've got a lot of people unemployed, but we've got more people with chronic kidney disease than people unemployed, which is a lot of people. And we don't know that. And when we find that, it's very late, and they have to go through dialysis. So what's on KDIGO 2024? There's a difference, a huge difference, and it was like this SGLT2 inhibitors appeared. And we have to use SGLT2 inhibitors almost for everyone. It's recommended for all the population with chronic kidney disease and albuminuria and decreasing of eGFR. But it's even more. They suggest treating adults with chronic kidney disease and normal albuminuria with SGLT2 inhibitors, because SGLT2 inhibitors has changed, has turned the nephrology upside down. It's the first time we are doing by making questions, answering questions. It's the first time in 20 years that renal is not a secondary endpoint. We have been for 20 years as a renal endpoint, a secondary endpoint that it could be okay or not. And it's the first time that patients come first, and then we think about what happened. The patient got well. Okay, let's see what happens in the mice models. We were willing to do that the other way around 20 years ago or 5 years ago. And it's the first time we can think of renal primary prevention, and I'm going to talk about that later. So this has been the long way of SGLT2 inhibitors. SGLT2 inhibitors started just being an anti-diabetic drugs, but from anti-diabetic drugs, they went a long way through right now with EMPO-Kidney and with DAPA-CKD that I'm going to talk about a little bit more. So the pivotal trials in cardiovascular safety, they had a secondary kidney endpoints, and these secondary kidney endpoints were so well, they found over 40 relative risk reduction of having the kidney endpoint. So they started thinking about, let's do something as a primary endpoint, and that was Credence. Credence trial found that most of the patients, 40% of the patients, could reach a decreasing in relative risk, they decrease in relative risk. And it was even more. It was the urinary albumin creatinine ratio that decreased a lot immediately after starting the medications, less than 6 months after starting the medications, and the relative risk reduction was 31%. It was totally different than any other medication we previously had, and this was because of an early hemodynamic mechanism of intraglomerular. So they said, let's go a little bit further. Let's go to DAPA-CKD, and DAPA-CKD started with a lot of different diagnosis. And they found, again, 39% of relative risk reduction with number of patients to treat, just 19 patients. We should treat 19 patients to find this relative risk reduction of chronic kidney disease. And this was a huge advance. And it was a breakdown on etiology. We didn't put just diabetic population in that trial. They had diabetic population, ischemic hypertensive nephropathy, and chronic glomerulonephritis. And they found that chronic glomerulonephritis did very well, even better than those diabetic populations that made before. And then empagliflozin did the same, but a little bit more. We are going one step at a time. Because we are nephrologists, we always go one step at a time. We are not cardiologists. And then they found let's go for a little bit more. People with normal bilirubin. So if we check the data very, very slowly, we will check that people with normal bilirubin benefit in relative risk reduction, and also people with macrobilirubin, and in different terms. So this is the way we've done. Now we've got credence with canagliflozin, 66%, 34% of relative risk reduction, DAPA-CKD, 40% of relative risk reduction, and EMPA-KIDNEY, 30% of relative risk reduction. We take all the ranges of chronic kidney disease, so we have to use this for our population. And this is the elephant. We can use SGLT2 inhibitors right now for almost everything, for people with chronic kidney disease in different stages, for people with high cardiovascular disease, for people with congestive heart failure, for people with diabetes and non-diabetes. So this is the elephant of primary prevention of chronic kidney disease. And the kidney disease progression has been decreased with using SGLT2 inhibitors. So SGLT2 inhibitors are doing better, and they are doing better in different diagnoses, in diabetics, in non-diabetics, in glomerular diseases, and even in patients on dialysis. I'm going to do that right now. In non-diabetic populations, being good, and it can also prevent the onset of acute kidney disease, which is a huge problem for our population because they already have chronic kidney disease, so they can develop acute kidney disease very often. And also prevent cardiovascular death and hospitalizations for heart failure. So right now, we can use this in the very huge cardio-kidney-metabolic diseases that we are talking about. And we have to always start treatment with SGLT2 inhibitors in patients with chronic kidney disease, with congestive heart failure, and patients, of course, with type 2 diabetes. And if you can see that the EGFR, they have been decreasing the EGFR threshold, so you can start SGLT2 inhibitors with a very low glomerular filtration rate, because it is safe for our patients, which is another point, because our patients has experienced some problems with other medications. So this is a very interesting thing about the kidney progression by glomerulonephritis. And talking about kidney progression of glomerulonephritis, we did this retrospective observational international study cohort that started in Spain, and then they extrapolated that with the immunophrology working group. And it was done in more than 400 people with proteinuria and different glomerular diseases. And what did they find? They found in 493 patients under angiotensin receptor blockers, and they were under immunosuppressants as well. You can see all the different diagnoses at baseline. They found that all the patients decreased proteinuria from baseline. That means, like, independently of if the patient was an IgA nephropathy, that we already know that SGLT2 inhibitors work very well with IgA nephropathy. They found membranous nephropathy, lupus nephritis, FSGS, anti-glomerular basement membrane, and vasculitis, fibrillary glomerulonephritis, and even in amyloidosis, they found a decreasing in proteinuria in 1 year of treatment. So even at 48% after SGLT2 inhibitors, and that was irrespective of the primary disease. They found that people with serum albumin over 3.5 grams were doing better, and they also found that people with higher body mass index were doing better. As we all know, SGLT2 inhibitors will help our patients to decrease a little bit of weight as well. So they will decrease hyperfiltration, and they will go better. And you can see here the eGFR slope at the proteinuria reduction. That means like people with higher proteinuria reduction did better in terms of eGFR. So they decrease eGFR more slowly than people with lower proteinuria reduction. So that leads us to the next question. And then, is it useful in dialysis? Can we use that in dialysis? And yes, this can be used in dialysis. The SGLT2 inhibitors have low diastability, but if you see here, they used people with type 2 diabetes as control with normal eGFR, and people under dialysis, of course, with residual renal function. Okay, we cannot use that in people without residual renal function, but in kidney failure group in dialysis, it had no serious adverse events reported. So they decided that maybe we could use that in people in dialysis. And Professor Guido Hirschman is not here, I think, but they started this very nice trial that's called Renal Life Cycle. This is a randomized clinical trial, and it's been doing with the helping of a charity donation of Piet Wolfsman Foundation, which is a taxi company that used to go back and forth with people on dialysis. So they saw the importance of helping them, of helping our population not to go into dialysis. So you can take a look at this. This is the web page of Renal Life Cycle Trial. We are going to go inside this trial as well. And also there are potential benefits we've seen in mice models in peritoneal dialysis. Their peritoneums got SGLT2 receptors. So we can inhibit these SGLT2 receptors also in the peritoneum, and they have potential benefits, and that can be an anti-inflammatory in diabetes, because there are decreasing of pro-inflammatory biomarkers in diabetes in mice models, and also cardiac benefits in PD population that sometimes has several problems in congestive heart failure. So they've seen these PD patients, they had started an empowered randomized clinical trial. I want you to check on this. This is the baseline, and there are another drugs, canagliflozin, empagliflozin, that are starting doing clinical trials in PD population. And last but not least, SGLT2 inhibitors in kidney transplant patients. We've been experiencing some difficulties thinking about what to do with kidney transplant patients, because they are a little bit more prone to have UT or to have some infections. But in Spain as well, we found that kidney transplantations could benefit a lot of using SGLT2 inhibitors. And these patients decreased proteinuria. These patients decreased the ability to be diabetics in the future. And in 6 months, after 6 months of we started that after 6 months of transplantation, and then we found that people that kidney recipients decreased body weight, decreased blood pressure, which is very important, decreased urinary protein ratio, and they decreased HbA1c. That means decreasing glucose. They get better in glucose control. So they did another trial here, very near here in Norway, with empagliflozin that could be good also in patients in kidney transplantation and in diabetes mellitus post-transplantation, which is a very huge problem in that population. So we can use SGLT2 inhibitors also in transplanted patients. And this leads me to the beginning. Let's go back from the beginning. Why not doing that? in primary prevention. And this is my boss. And this is what we do with my boss. Let's take a look at empagliflozin. Let's take a look at empakidney. And what we found was the absolute difference was better for people with urinary albumin-creatinine ratio over 300 milligrams per gram. But if you see data annually, this population that had below 30 milligrams per gram did better. They didn't decrease EGFR, and they didn't have albuminuria in the future. So we do not have people to go into dialysis. We do not have people to develop chronic kidney disease. We do not want our population to be albuminuric. So why don't we start this before? Because if we start before, this is the difference. This is empakidney, and it can make a difference in people with EGFR of 20 milliliters per minute. You will have these people without dialysis for 1.9 years. If you do that 26.6 years before, they won't ever go to dialysis because you will prevent our populations to go into dialysis. And preventing population to go into dialysis means a lot. Means human suffering, means losing quality of life, means healthy, and means also environmental problems, because as Professor Seminka said before, we need a lot of water consumption and a lot of energy to do just one dialysis session. So if you start with 20 milliliters per minute, you are going to avoid 301 dialysis. If you do that for 26 years before, you will avoid 4,166 dialysis sessions, which is a lot. And you will, your patients, of course, will enhance the benefit, and they won't even need dialysis in the future. So that's my last slides. We've got SGLT2 inhibitor facts. They improve outcomes, they improve cardiovascular outcomes, they improve CKD, kidney outcomes, cardiovascular, congestive heart failures. We can use that with or without diabetes in different CKD etiologies, in different CKD stages. We've done that with a lot of patients, more than 40,000 patients. This got biological plausibility. We have to identify different patient profiles, but all of them seems to have a benefit, and independently of hypoglycemic effects. These benefits are independently of the ability of the hypoglycemic drugs. The effects are very strong. We do not have an increase of acute kidney injury. And of course, KDIGO guidelines endorse the use of SGLT2 inhibitors in our population. So, and that's the message, floating it now or regret later. Thank you.